Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record, and also please remember to fill out the program evaluation, and if you could give us any ideas in regards to future topics or future speakers that you'd like to hear. A reminder that next week we will not have Grand Rounds. Today we actually have co-presenters. One of our presenters is Katie Albrecht. Katie received her Master's of Physical Therapy from the University of Iowa and is now a part of the Rehab and Wellness Department here at Mary Greeley. And our other presenter is Dr. Bryan Graveline, who is a gastroenterologist, master educator, and author of the critically acclaimed GI Pearl series. they're here to update us on pelvic floor pathology. So please join me in welcoming Bryan and Katie.
Thank you. Well, thank you. It's actually, I guess I've got this. Can you all hear me okay back there? Yep. Okay. Well, it's going to be the Katie and Bryan show today. Katie Albrecht is our physical therapist. She's hiding back there. I'm going to lead off and give kind of the introduction to some of the diseases of the pelvic floor and talk about how we diagnose them. And then Katie has the important role. She's going to talk about what we do to fix these problems. And actually, they are common problems. And it's probably... Pardon? Oh, there we go. All righty. Pelvic, we don't think, there's certain areas of the body we don't think too much about. The throat is one of them. We don't really think too much about that until you get diseases there, like ALS and things like that, and all of a sudden you realize that's kind of a critical area of the body. Another critical area is the pelvic floor. Again, you don't think too much about that until problems start to come up. And when problems come up, then all of a sudden you realize what an important area that is. So we're going to talk about several diseases of the pelvic floor. And as I said, how we figure out what the diseases are, and then Katie's going to tell us what we do about them. And we're going to tag team it. I'll talk first, and then Katie will follow after I talk. Katie's got a nice PowerPoint presentation. I don't have that, so I'm going to actually talk to the audience and have you guys answer questions. So you kind of have to be awake and put your thinking cap on. So hopefully some of you may know some of these answers. Anyway, I'm going to start out with the first problem of the pelvic floor that we're going to talk about, a potential problem, and that's constipation. As you know, constipation is common. Lots of people get it. It's a big complaint for a lot of people, and when they see us with something, we probably want to help people with. So I'm going to start off right off the bat by taking a poll, by asking a couple of questions. Constipation per se, we have a lot of patients come in with that. Is it dangerous? Is it harmful? If people are constipated, they don't have a bowel movement for many days or even weeks, is that harmful to people? We'll take a vote here, so you gotta not be shy. How many people would vote that yes, if you go days or even a week without a bowel movement, it will damage the body? Okay, and how many people say no? Okay, so we're all agreed it is a problem. The truth is it can damage muscles and so on. It really doesn't damage the internal milieu of the body. It doesn't lead to auto-poisoning or anything like that. But it's still a problem, and it's a problem because it's very uncomfortable, it can be painful, and it's very annoying to people. Second question for you would be the standard treatment is laxatives. We all know this, they're over the counter. Are laxatives safe or dangerous? Taking all comers, anything you can get over the counter, if you were to use these laxatives, say on a daily basis, the question is, would that be safe to do, or is it not safe? How many people say that would be safe? Okay. How many people say it's not safe? Actually, the minority wins. It is safe. This is an old wives' tale. It's actually not an old wives' tale. They did research back in the 40s, and it looked like if you use certain classes of laxatives, they're called cathartic laxatives. These are things like Senna, Ducalax, X-Lax, things like that. These are the cathartic laxatives. They used to think that could damage the bowel. But those studies were all repeated in the late 90s and early 2000s and found it not to be true at all. It doesn't cause any damage at all. So laxatives are safe. But as we're going to talk about, they don't always work. Sometimes for certain types of constipation, they don't work at all. So while they're totally safe to use, it doesn't work for everybody. Sometimes we need other types of treatment. However, if your patient is using laxatives, there's no harm to it. The question is it helping or not? Some types of constipation, it helps. Sometimes it doesn't. And this is where I'm going to put you on the spot. And I see there are a couple of family practice doctors here and so on. When people have constipation, it turns out there are different types of constipation, different causes. And there really are three main causes. And if we're going to treat constipation, we have to know which type it is, because the treatment is really different depending on what type of what the cause of the constipation is. So I'm going to see if there are any brave souls. Does anybody know any of these types of constipation? There's three of them. Can anybody come up with even one of those types? Gary, I'm looking right at you. Yeah, you right to the point. This is exactly what Katie will be talking about. There's something called pelvic floor dyssynergia, and that's a long word. It's actually fairly common. Women tend to get this a little bit more often than men, and it's much more common than we realize. And the idea is this: when we're not going to the bathroom, we're not having a bowel movement, we have a bunch of muscles that kind of keep everything closed. We have sphincter muscles, which are just circular muscles right around the anus and the very distal rectum. But we also have pelvic floor muscles. And the pelvic floor muscles are naturally tonic. They naturally stay a little bit contracted. And they tend to pinch on the rectum and even kind of bend it a little bit. And that keeps stool and stuff from falling out. When people go to have a bowel movement, those muscles have to relax. Those pelvic floor muscles have to relax to allow the rectum to straighten out and to allow things to come through. Now, that's subconscious. If we go to have a bowel movement, we don't consciously think of relaxing those muscles. It's just supposed to happen. For some people, particularly, again, women more often than men, that doesn't happen. They're not conscious of it, but those muscles don't relax. They just kind of spasm or they just stay tonically contracted, and it's very hard to get stool out. It's kind of like driving down the freeway with your parking brake on. You can step on the gas all you want, which is to say add laxatives to kind of push things through, but you still have the parking brake on. So the goal with pelvic floor dyssynergia, one of the causes of constipation, is to release the parking brake. And again, this is what Katie Albrecht is going to really talk to us about, how we can do that. Does anybody know the other two types of constipation? There's one more type that's pretty rare and one type that's even more common than pelvic floor dyssynergia. Anybody know what the other two types or causes of constipation are? And all constipation falls into these three categories. Gary, can I put you on the spot again? That would actually be kind of in the realm of a pelvic floor dyssynergia, although it's a little different disease, and little children get that. But the other two types, which are the type that's uncommon, is called pelvic floor colonic inertia. That's a very slow colon. It's where the muscles or nerves in the colon are damaged, and oftentimes it's congenital. There's people who just aren't born with good muscles or nerves. And the colon, instead of peristalsing along nicely, just kind of goes, barely peristalsis. And that's fortunately, it's very rare because that's very hard to treat. It causes all sorts of other problems. Those people, when we see that, we actually send up to tertiary centers, usually Mayo Clinic or University of Iowa, for some advanced testing and advanced treatments. So that one's rare. Pelvic floor dyssynergia we just talked about, that's not uncommon. But the most common type of all is actually what we call functional constipation. That's probably a form of irritable bowel. It's where the colon tends to spasm and stool can't get through too easily. And it's very frustrating for people. That's the type that actually does respond pretty nicely to laxatives. So we have three types of constipation, and if a patient comes to us and says, oh, I've got this bad constipation, our treatment really varies depending on what type it is. So we have to figure out what type of constipation it is. And to do that, we do tests. There are two tests that we can do. One is really easy, but I'll bet nobody here has ever done this test because I've never seen anybody else do this test, or I've never seen it in the chart. And the other sounds really weird, and I'm certain you've never done this, but we'll tell you about it. Any idea what these tests might be at all? Any thoughts? Pardon? You got it, a Sitzmarker study. Yeah, and we get, in my field, I get consults all the time for constipation, and nobody's ever done a Sitzmarker study, and it's so easy to do. What a Sitzmarker study is, it's just a capsule. You have this capsule with 24 little plastic O-rings. Department of Radiology has it because it's going to be paired with an x-ray. We have it in our office. If you see patients who ever get constipation, you should get some in your office. You have your patient take the Sitzmarker, swallow it, it's a big capsule. 5 days later, you take an x-ray and you see where those Sitzmarkers are. And that can help tell us what type of constipation this is. If the Sitzmarkers are all gone, or most of them are gone, that's functional diarrhea. It's just bowel spasm. There's no disease or anything bad in there, and you can treat with laxatives. If the Sitzmarkers are all lined up in the rectum and in the sigmoid, that's very good evidence that this is pelvic floor dyssynergia. In other words, probably what's going on is there's either a blockage in there, or more likely, at the very bottom of the rectum, or more likely those pelvic floor muscles just aren't working very well. They're spasming, they're not relaxing. The third possibility is that all the little Sitzmarkers are all around the colon. That still can be pelvic floor dyssynergia, or it might be that colonic inertia that we talked about. So that's a really good test, and it's really easy to do. It's painless. You just hand the patient the Sitzmarker, say, come back in 5 days, let's get an x-ray. it's nice to tell the radiologist what you're looking for because they'll count the Sitz markers for you. More likely to see them. They're kind of tiny. So that's one test. There's a really weird test that will tell us much more accurately whether there's pelvic floor dyssynergia. And since pelvic floor dyssynergia is so common, so many people have it, a lot of times we have to do this test. And it's a strange test. We do it in the endoscopy lab, and Katie does it up in her lab too. And I see some of our endoscopy nurses here, and I know they know the answer. So the question is, what is this weird test that will tell us if people have pelvic floor dyssynergia? Jody or Jill, I see you guys up there. The question is, we've got a patient with constipation. We think that's say a 50-year-old woman or a 60-year-old woman. We think maybe she has this pelvic floor dyssynergia where the pelvic floor muscles are not relaxing. We want to know that because if they have that, we're going to send them to Katie Albrecht to get fixed. But we want to know. So there's a test we can do that will tell us that. It's the weird one Yeah, an anal motility, and the part of the anal motility, this sounds really weird, is a balloon expulsion test. And here's what we do, and we do this in our lab, and Katie does it in her place too. Patient lies on their side, we take a little catheter, it has a little balloon on it, which is inflated, we lube it up, and we actually put it up in the rectum. Then the patient hops up and sits on a commode, we kind of shut the door, or give them some privacy. The catheter comes out, we actually inflate the balloon with about 50 mLs of water. We say, okay, try to poop it out. And this is really crude, but it works. And the patient's given, and there's different guidelines. It used to be 1 minute to poop it out. The current guidelines say actually probably 2 minutes. If they can't poop this balloon out in 1 or 2 minutes, that's a very good evidence of this pelvic floor dyssynergia. And that gives the answer. That's what's causing the constipation. If they can poop it out quicker, then they probably don't have pelvic floor dyssynergia. So that's really the gold standard test. It sounds really weird and strange, but we do it, and it gives us to the answer, and then we can get the problem fixed, so it's worth doing. So constipation, really common problem. Lots of people have it. It's painful, annoying, icky. We want to treat it, but to treat it really properly, you got to know what type it is. Is it pelvic floor dyssynergia, in which case you got to do the balloon test. You should do the balloon test. Is it functional constipation? The Sitz marker test will tell us that. Is it that rare case of colonic inertia? We want to know that so we can get them to the right place. Again, the Sitz marker test and the balloon test can help us with that. So that's kind of the story on constipation. I'm going to segue right into a couple of other pelvic floor anomalies, and then of course, then I'll turn it on over to Katie, and she's going to tell us what we do about all of this. So we're talking about constipation, so I'm going to kind of switch to the opposite problem, and a great thing to talk about at lunchtime, I suppose. But we'll talk about diarrhea. And my question for you is this. A patient comes in, say it's an elderly woman, we'll say. She's in her 80s, and she complains of diarrhea. There's a question you need to ask if you see patients like this. It's a critically important question. If you don't ask it, you may totally miss the diagnosis. The patient says, oh, I have horrible diarrhea, it's just terrible, I hate it, what are you going to do, how can you fix it? What question do you want to ask your patient? It's a critical one to ask. In other words, what might they have? Fioris. Exactly, yeah. Are you having accidents? A lot of times, especially in older people, but I've seen this in young people too, fecal incontinence or having accidents is the problem, but they don't call it that. They're too embarrassed. It's kind of embarrassing to talk about having these accidents with stool coming out, so they just call it diarrhea. And I can't tell you the number of times I've had patients referred to me for diarrhea. They saw their primary care doctor or whatever, came to see me with diarrhea. My first question is, are you having accidents? And it's kind of funny, as the floodgates open, oh yeah, I have horrible accidents, it's terrible, da da da. And that's really where the problem is. It's not diarrhea per se at all, it's having these accidents, what we call fecal incontinence. And that can really, really be a problem. There are two main causes of fecal incontinence. There's kind of a minor cause and a major cause of fecal incontinence. And I'll tell you the major cause right off the bat. That's where the muscles get weak. The rectum maybe no longer senses stool too terribly well. The sphincter muscles get weak for a variety of reasons, especially as we get older. And if that system isn't working, the sphincters can get a little bit lax, stool can leak out. And that's fecal incontinence. There's a second cause also, and this is something to be aware of. So certainly if you have fecal incontinence, you want to send the patient either to us or to Katie, but you might check for this other cause of fecal incontinence. And this is where you got to put your thinking cap on. Can you think of any other causes of fecal incontinence besides weak sphincters and so on? Any thoughts on this? This sounds odd, but constipation. there's something called overflow diarrhea, where if people are badly constipated, they've got stool all throughout the colon, what happens is fluid just kind of, instead of the stool coming out like it should, I mean, it kind of dribbles out, but lots of fluid swells up around it, and the fluid keeps coming out. And a lot of times people are incontinent with that. So that's something we always have to keep in mind. Is the problem really horrible constipation? And oddly enough, even though they complain of leakage and kind of loosey, watery stools, if you treat with laxatives and clean out the colon, that will get rid of the problem. So how are we going to figure that out? The patient's in your office, they talked about diarrhea, you ask if you're having any accidents, Dr. Salty asked that, they say, yes, that's really the problem, I'm having accidents and so on. We want to make sure they don't have this overflow diarrhea, which is really due to horrible constipation. How can we figure out if they have that? There's an easy way to figure it out. Any thoughts? You can do a rectal exam and you might find a fecal impaction, but there's an even better test. A simple x-ray is all you need, just a KUB. Because you can see stool on an x-ray. So you just send them down to the radiology department. You can do it right then and there. Just say, please look for obstipation. That's like really bad constipation. And you'll get a report in 10 minutes or so. They'll shoot a quick x-ray. And if they see stool all throughout the colon, that's your answer. And you skip sending them to us or to Katie, just treat with laxatives at this point for the constipation. If it doesn't get any better, then we might do some of that constipation workup at that point. So that's a really easy way to distinguish between the two. Most people who have accidents do not have this overflow diarrhea, but a few people do, and we do catch it on occasion. And it's so easy to catch. You just need to get a KUB. That's all you have to do. So just check that. Checking that is an important thing to figure out what's causing the accidents. That said, the vast majority of people who have fecal incontinence, having accidents, actually have weak sphincters. They have poor sensation in their rectum. And there's actually kind of two ways to treat this. There's an easy way, because a lot of things start off easy, which works for some people but not everybody. And you should probably start with this. And then if it doesn't work, again, our default mode is back to Katie Albrecht for treatment. But what's the easy thing to do? It's probably you should do before you send them to us or to Katie, because she'll do this first and it might solve the problem. Person complains of accidents, you got your KB, no constipation or anything like that. Their rectum can't sense stool or whatever, and so on. There's something easy you can put them on that, yeah, Gary got it. Say it again. Yeah, Metamucil. Of all things, psyllium fiber does two things. It kind of acts like a sponge, so it soaks up any excess fluid. That helps with the incontinence, and it bulks the stool up. That allows the rectum, which maybe isn't sensing things too terribly well. You get bulkier stools, it can sense a little bit better. Maybe a third to a half of the time, that will solve the problem. So putting them on psyllium fiber, which is Metamucil. They have to take it every day. It takes a week or two to see if it works. So anybody who complains of that, I would start them on that right away. Tell them this might work, it might not, but it's easy to do. So why don't we try that? Psyllium fiber, by the way, and you guys may not be aware of this is Metamucil, but it actually comes in different forms. The really gross, icky, kind of disgusting powder that you pour in water and drink and yuck, that's the form everybody knows about, but it actually comes as cookies also. They're called wafers, and it's much more edible, it's much more palatable, and it works just as well. So what I do is I put people on the wafers instead. I just go to the grocery store, ask them for the wafers. They're like apple flavored and cinnamon flavored, and they're not like, they call them cookies. They're not like Dough Biz double chocolate chip cookie. They're not that good, but they're edible. They're more edible than the powder. People can have the powder if they want, but I don't know anybody who likes that stuff. It's kind of icky. The wafers aren't bad. So 2 wafers a day for a week. See if and a lot of times, maybe a third to half the time, the incontinence goes away and the problem is solved. It's really easy to do. Again, I get a lot of referrals for this. Diarrhea, you find out they actually have incontinence. You make sure they don't have overflow diarrhea. They don't. Put them on their Metamucil wafers, get a call a week later, how are you doing? It's gone, I'm fixed. Easy to do, could easily be done in primary care instead of referring to us. We're happy to do it, but it's something that you guys can all do, you guys can do in your clinic. If it doesn't work, and a lot of times it doesn't, then they've got bigger problems with their musculature and so on, and it's time to send them to Katie Albrecht. So that's what we do next for fecal incontinence. The last disease I kind of want to talk about, last problem is a not uncommon problem, but it's pain. It's pain down in the pelvic area, but it's not pelvic pain. What patients will tell you is it feels like it's caught up in their rectum. And every once in a while, maybe all the time or part of the time, they'll feel this pain. It just feels like something's up in the rectum and it hurts, and it's not horribly painful, but it's uncomfortable and they don't like it. And you'd think, well, maybe there's a tumor up there or something like that. There hardly ever is. People do get rectal cancers, but usually don't really feel it as pain. We'll do a little scope and make sure, but odds are if you have pain up there, you won't find anything. Instead, there's a different thing, a different problem. Does anybody know what that, it's kind of a classic story for, what that's called or what that is? When people complain of getting this pain, it feels like it's kind of up in the rectum just a little bit. Does anybody happen to know what that might be? Any thoughts? You got it. I heard somebody yell it out. Yeah, levator syndrome, exactly. And what that is, that's where the pelvic floor muscles spasm. And even though it's the pelvic floor muscles, you perceive it as kind of upside in the rectum. And it's a problem with, it's a spasm problem, and it causes pain and so on. So it's actually not uncommon. And I'll put you on the spot. Sometimes it'll occur like in the middle of the night, and it just suddenly, whoa, it really gets people, and it wakes them up, and they're in a lot of pain, and they kind of walk around, and they don't feel good, and after a little while it goes away. There's actually a name for that. Any idea what that's called? That's called proctalgia fugax. I don't know if you've heard of that or not. It's just a form of levator syndrome. It's the same thing, but it's where it kind of strikes people all of a sudden. Usually in the middle of the night, it kind of wakens people out of sleep, and that's called proctalgia fugax. There's two ways to treat levator syndrome. Proctalgia fugax, which happens very sporadically, this is really odd, and nobody knows why this works, but it seems to work pretty well. But beta agonist inhalers, like albuterol or whatever, once they get the spasm, if they have an inhaler, this has nothing to do with asthma or anything else. You use the inhaler, and it makes it go away pretty quickly, which is really weird. They don't know what the mechanism is. Nobody knows why it works, but it seems to work pretty well. The other way to treat, of course, is to work on those pelvic floor muscles to get them to relax and so on. Who is it who works on pelvic floor muscles? Katie Albrecht does. So with that, it's actually pretty straightforward. We'll usually do a little flex sig, make sure there's nothing in the rectum. There never is. It's always normal. We'll also do a brief exam. We do a rectal exam, and that's actually important. If it's levator syndrome, you can actually, once you put your little finger in and you kind of feel around, if you palpate, it hurts. I mean, a rectal exam is not much fun, but it shouldn't hurt when you, at the tip of your finger when you palpate around. But if it's levator syndrome, as you press on it, it kind of hurts. Ow, ow, that hurts. And that's more evidence that it's levator syndrome. Also, the coccyx, that's our little tailbone, the very tippy end of our tailbone. You should press on that on the outside. If that hurts, that's a coccyx problem. That's called coccydynia, and you treat that with nonsteroidals. I've never seen it, but they talk about that. I don't know, Gary or Fioris, have you guys ever seen a case of that? Gary's waving his head yes. So yeah, it's rare. So you can, on a very brief exam, just a rectal exam and see if there's tenderness on palpation. It kind of hurts. Okay, that's probably it. And just press on their coccyx on the outside. If it doesn't hurt, then it's not that. If it's tender, that's levator syndrome. And if they're having that pain all the time, like all throughout the day, then they need physical therapy for it. So to sum up, pelvic floor problems, 3 different diseases to consider. Constipation, the type of constipation that's caused by the pelvic floor, that's that pelvic floor dyssynergia. Laxatives don't work very well. You need physical therapy. The second type is fecal incontinence. Metamucil sometimes helps, but often doesn't. If it doesn't, you need physical therapy. Levator syndrome, if it happens all of a sudden, just sporadically, all of a sudden at night or whatever, you can try a beta inhaler. But if it's happening all day long, you do your exam and it's tender on the inside there, it's levator syndrome, that person needs physical therapy too. They all need Katie Albrecht, and she's up next. And that's the story on these. All right. Yeah.
Do we need to evacuate? Okay, can you guys hear me okay? Yeah? Okay. What a perfect introduction. Thank you. I wonder if this is my, oh. Yes. Okay. I wanted to just introduce myself a little bit, tell you a little bit more about myself. Dr. Graveline didn't tell you this, but he likes to call himself world's greatest dad. Yeah. So I had to include this picture. This is my 2-year-old daughter, Ruby. I brought the little potty chair down. We were going to start our potty training. I brought it down, and it only made it as far as, like, the kitchen. I just set it down, and I started doing something else, and next thing I know, I turned around, and here she is, sitting on the potty with her book. So yes, I have a 2-year-old and I have a 12-year-old. So toddler and middle school, I do not feel like the world's greatest mom ever.
On my little flyer, I put MD, WGD for World's Greatest Dad, but my story is different. I have 3 kids, 2 of whom are daughters, and they often will say, you know, Dad, if you'll buy me that pair of shoes or that skirt or that whatever, you'd be the world's greatest dad. Oh. And I've done that enough that I figured I'd earned the initials.
You're a sucker. So I went to physical therapy school at the University of Iowa, and straight from there started working at the University of Iowa Hospital, where I was lucky enough to work for about 10 years. I had a very unique role. I worked about 50% of my time in our physical therapy clinic, seeing women with pelvic floor muscle dysfunction. The other 50% of the time I spent in 2 different gynecologic specialty clinics. One of them was the urogynecology clinic, seeing women with urinary incontinence, fecal incontinence, pelvic organ prolapse. And then the other specialty clinic was the vulvovaginal disease clinic. So these are women with vulvar pain, sexual pain. And there was just a tremendous amount of overlap with these patients and patients who are having constipation, particularly, sometimes fecal incontinence. But it wasn't until I moved to Ames. I got married in 2011, moved to Ames, started working at Mary Greeley, and it wasn't until I was here that I really got to be part of a team with the GI physicians and nurses. And it's been really great. So my role as the women's health specialist, and I had to put an asterisk here because Dr. Graveline pestered me until I finally agreed to see men. So I will see male patients for GI related issues, but most of what I do is women's health, and that includes urinary and fecal incontinence, pelvic organ prolapse, the constipation, particularly when it relates to a muscular problem. My main passion is pelvic pain and sexual pain. And then I also see women who are having just general musculoskeletal pain relating to their pregnancy. And then completely off topic, I do a lot of our post-mastectomy care and lymphedema, compression, fitting, that type of thing. Sorry, wrong direction. There we go. So my goal is, I'm going to just really simplify the idea of pelvic floor muscle dysfunction and sort of categorize it so that you all feel like you could easily identify it through a history and physical exam, and then relate it to how it might correlate with a specific bowel issue. So we'll talk about the specific muscle physiology of the pelvic floor, taking a history, doing an exam, and then what the treatments are. And I mean, the treatment is the most exciting part, but it's so dictated by those other things that it's like once you know those things, the treatment is really quite obvious. So brief anatomy review, female pelvis. Pelvic floor muscles, you can tell just by looking at them what their function is. Their function is to support the pelvic floor, pelvic organs, and closure of the anus and the urethra. So if we're talking about what it means to have a normal pelvic floor muscles, I think of muscles in 3 different ways. So I look at muscle strength, I look at muscle length, and I look at motor control or coordination. Okay, so if we're first talking about strength, pelvic floor muscle strength is something that you can measure. Urogynecologists use a Brink scale usually. Physical therapists just use regular manual muscle testing, 0 to 5. But for me, the only thing that really matters is, are you able to squeeze these muscles enough that there is a lift? Are you able to lift them against gravity or not? And that's sort of how I classify them, because that's what helps me dictate what position these patients should be in to do their exercises. When we look at the data for pelvic floor muscle strength, most of it relates to urinary incontinence, stress incontinence in particular. We have extremely strong evidence to support doing Kegel exercises for stress incontinence with cure rates that are fairly high, 44 to 67%. And a little side note here, it can be just that simple. So adding biofeedback, adding vaginal cones or weights, adding electrical stimulation, there is 0 added benefit. You just got to do the exercises. So that's what I'm looking at when I'm considering muscle strength. When we're talking about muscle length, I think this is probably the most important slide, so I'll spend a little bit more time on it, because I think it's a really, really important distinction to think about the difference between a short muscle and a muscle with high tone. They're different, and they imply different treatments, okay? So the first thing to understand about muscle length, if you look at that curve, is that it completely dictates muscle strength. So every muscle is able to reach its optimal force-generating capabilities at a normal length. So if you've got a muscle that's really, really long or really, really short, on either end of the spectrum, you're going to see weakness. And most of the time when we think of pelvic floor muscles, we're thinking of long muscles. The person who's pushed out 10 babies or had constipation their entire life and has just been pushing and pushing. If left to their own devices, these muscles tend to get long and stretched out and weak, okay? But I want you to be very aware that weakness can also present from muscles that are too short. So length is something that's adaptive. We've all seen this. Patients who are in a wheelchair are fairly quick to develop knee flexion contractures, hip flexion contractures, and there is such a thing as a pelvic floor muscle contracture. And I think that's a really important thing for us to think about when we're considering treatment. So does that slide make sense to everyone? Because I feel like that's the key. So we've got strength, we've got length, and then we have motor control or recruitment patterns or coordination. So I'm looking at the quality of the pelvic floor muscle contraction and relaxation. When I ask someone to do a Kegel exercise, what does it look like? Are they really able to squeeze just their pelvic floor, or is it this tremendous bridge up off the table, or you wouldn't believe what people do? And is it timed well? Does it take them a good 5-6 seconds to reach their optimal force? And then when I say let go, what happens? Does it let go? Is it just kind of jerky lengthening? This is something that's important also when we think about length. If you've got a contracture, nothing happens when you ask them to contract, or when you ask them to relax, and when you ask them to push. It just stays there. So those are the things that I would be looking for on an exam. And then when we think about what is necessary in order to have normal defecation, and Dr. Graveline already described, we have this pressure system that's in an ideal world supposed to work just perfectly, where the pressures in the rectum increase and the pressures around the pelvic floor and the rectum, distal rectum, are going to decrease and allow that stool to come out. Well, what if you have a pelvic floor muscle contracture? I don't know that that's going to come out. Do you have enough muscle length to really allow that stool to come out easily? And this is really important when we start thinking about use of biofeedback for constipation, because imagine how frustrating it would be to both the therapist and the patient if they present with a true contracture, that on an exam, they can, when you ask them to squeeze, they squeeze just a little. When you ask them to relax, nothing happens. And you ask them to push and nothing happens, or they just squeeze again. That's really frustrating to try to go through biofeedback when you just don't have the length to even do what somebody wants you to do. And so for that reason, sometimes I will see patients in my clinic just for some passive muscle stretching to get some length that they're then able to use, that we can take to the lab and really make use of that biofeedback system. So I'm just going to give you a scenario. Let's say we have a pelvic floor muscle dysfunction that presents as someone with really long and weak, maybe even damaged pelvic floor muscles or sphincter. So this is going to present as incontinence, maybe urinary incontinence, maybe fecal incontinence, maybe maybe some prolapse as well. And this, it seems pretty clear when we see that this is what the problem is. Great, we need to do some muscle strengthening. We need to do some Kegel exercises. I mean, I really feel like breaking it up like this makes it really easy to determine what we're supposed to do about it. However, it gets a little more complicated when that weakness is because those muscles are too short. So you've lost sarcomeres in series. You have this contracture, so to speak, of your pelvic floor muscles. Now that can present in all different kinds of ways. You could still be leaking. You could still be leaking urine because your muscles are just inefficient. They're not, you don't have the ability to really contract like you should. But most of the time it's presenting with constipation, this dysenergic pattern where they've just sort of lost their way, and very frequently pain, specifically pain with intercourse. And the main thing with these patients is to see if you can figure out why are their muscles so short? Because, you know, the natural history of these muscles is just to lengthen and stretch out over time. It takes something fairly special to make them do this. We don't just get spastic pelvic floor muscles for no reason. And so I see that as a really important role for me, is finding out what's the source of that muscular response. It is almost always something relating to bladder, like an urgency frequency syndrome, interstitial cystitis, something like that, where they're constantly having to hold those muscles. A bowel issue, a lot of patients with Crohn's disease in particular who are just constantly trying to not leak, to make it to the bathroom, to shut off that urge. Coming from the vulvovaginal disease clinic, my bias is certainly that there's a skin-mediated source of pain, and so I see that in a lot of my patients. And then trauma or abuse, and that's something that is unfortunately, that's a real concern and something that you should ask about because it will have a huge impact on how you approach your treatment plan. So what if the problem is really just motor control and coordination, maybe a little bit of sensation issue? When we do this biofeedback, this manometry, it's really interesting. We get to see what the pressures are that are being generated by the rectum to push the stool out, and what kind of pressures exist below in those pelvic floor muscles and sphincter that are either allowing the stool to come out or not. And so there's 4 basic patterns that we see. The first 2 exist where, when you ask someone to push, they are instead contracting. So you might say, push, bear down, bulge, like you're going to pass gas, like you're going to have a bowel movement, and instead those muscles just contract. And then the other 2 are just where instead of lengthening or relaxing, they just stay the same. They just maintain that relatively high pressure. And then there are also varying degrees of how much the rectal pressure plays a role as well. Are they able to really generate a push that's strong enough? In April, towards the end of April, I'll be going to a course that looks more specifically at rectal sensation and how to use the balloon to help train people who either have hypersensitivity or hyposensitivity. So I can report back after the course in April. So everybody loves my poop chart. I show it to everybody. I hand it to the patient and they say, "Oh, that's neat." So I really think that history and physical exam are the most important thing. I know that there's tremendous value for getting x-rays and SITS marker studies, et cetera, because they give you very valuable information. As a physical therapist, all I have is a history and physical exam. And so it is very thorough. So I really like to get a really good idea of what their chief complaint is. Maybe the referral says diarrhea, but I bet it's really fecal incontinence. Or is it constipation? So I'm just asking loads of questions. How often do you poop? What does it look like? Is it hard? Does it hurt? All kinds of things. But I also want to know about their obstetric history. Do they also have bladder symptoms? Are they leaking urine, or do they feel that constant sense of urgency? Do they have vulvar symptoms? Are they having sexual pain? I ask questions, basic questions about diet and hydration. So people who, and they're out there, who eat just McDonald's and Mountain Dew, no water, no vegetables, no fruit, that's a really easy place to start. And I like to keep things simple. So I ask those kinds of questions. It's important to know what kind of medical history you're dealing with. Are they on oodles of narcotics? That's going to make treating their constipation difficult. I like to know about their social history, what kind of jobs they have. You nurses are the worst because you never take a bathroom break. Those are important things for me to know. And then I need to know about that history of possible abuse, especially if it involved any kind of rectal penetration. That's something that I need to be respectful of, we all need to be respectful of, and it's going to impact the way that I formulate my plan. So the bottom line is ask. And then a physical exam, don't skip it. You should do it. You can get all kinds of great information from a physical exam. You just have to look at their bottom, look around the anus. Is there fissuring? Because boy, that would sure hurt every time you're trying to have a bowel movement, and that would sure make your pelvic floor muscles contract. Are there hemorrhoids? Are there other things that may be more worrisome? Use your fingers and see, what do these muscles feel like? Do they hurt when I try to stretch them? Do they feel stiff? Or do they look like they're just really weak and open? And I also extend that to the abdominal muscles as well. And then looking at their motor control. So you can have, just with a vaginal exam even, doesn't even have to be a rectal exam, you can just ask someone to contract their pelvic floor muscles and then say, okay, now let them go, and then see if you can push them out. Bulge as though you're going to pass gas. And if every time you ask them to do that, they just contract again, that's probably a dysynergic pattern. And that would be worth sending to Dr. Graveline or myself so that we can help educate them further. So the treatment now seems really easy, right? If it's a short muscle, it needs to be longer. If it's a long muscle, it needs to be shorter. So, the first thing I think if you are identifying a short pelvic floor is figuring out what the source is. So when I get a referral, don't be surprised if I call you and say, hey, did you know that they have this, or this? And I think that's why this problem started to begin with. So sometimes you have to back up a few steps. You need to address just basic bowel habits. Are you eating enough fiber? Count how much fiber you're really having. I give you 2 days. See what you think. Because people always say, oh, yeah, I eat plenty. And then when they count, they say, oh, it was only 8 grams. And it should be closer to 30, 35. Are they drinking enough water? What's their activity level? And those are such easy things to manipulate. If it's a short muscle, we need to do some stretching. Either I need to be doing the stretching for them, or I need to give them a tool with which they can do the stretching themselves until they're able to demonstrate normal active range of motion. Squeeze, let go, push. And then we can use the biofeedback system to help get this all coordinated a little bit better. If it's a long muscle, if it's fecal incontinence, we're doing the same type of bowel habit training, I suppose you could call it. We're doing pelvic floor muscle strengthening, and most of the time without biofeedback. So Medicare does not cover biofeedback for fecal incontinence because frankly we don't really have that great of data that you need biofeedback. You just need stronger muscles, and we can do that with the home exercise program really well. And then using the rectal balloon for sensory training, which I will learn more about next month. So my bottom line is that I think this is a really important thing to address as a team. Complicated problems require complicated solutions, and communication is really important. And I think educating your patient is the key to what's going to help them be able to maintain whatever they're able to get. I'll wrap it up there so we have time for questions. So in my chronic pelvic pain population, about 80%. So it's unfortunately much more common than we'd like to think, and I mean, especially with people who are coming because they have problems evacuating, pain with intercourse. So, I mean, I think my patient population is certainly skewed towards the more prevalent side, unfortunately. You all know everything? Well, thank you so much for inviting us.